Good morning, students. I'm Dr. Anagha Agrawal from Department of Public Health Dentistry, Nursing by Patel Dental College, Visnagar. In a series of lecture, when we started with general epidemiology, we knew what is the epidemiology is all about, what are the principles of epidemiology, tools of epidemiology, what is the prevalence, what is the incidence, and what is the relationship between the two, and what are the uses of epidemiology. Then we went for all the epidemiological studies where we studied that there are two main epidemiological studies, that is observational study and experimental studies. Now, the observational studies, as we all know, can be divided into descriptive study and analytical studies. So, analytical studies have various types, out of which one, that is the case control study, we've already studied in our previous lectures. Now, this is the very important second type of your observational analytical study, that is cohort study or longitudinal study, or also known as prospective study, incidence study, or forward looking study. So these are all the names which can be taken instead of cohort study. So what do you mean by cohort? It's a group of people who share the common characteristics or experience within a defined time of a period. So similar people who have similar characteristics, they are being called as cohort. What are the distinguishing features of a cohort? As cohort should be identified prior to the appearance of the disease. So before the disease has appeared, as we see in case control study, the disease has already appeared. Then only we can take cases. But here, in cohort study, we do not do this. But we identify a cohort which have similar things into common, but they do not have any disease right now. The study group is followed over a period of time. So we follow this group over a period of time, and the study proceeds from cause to effect. So the study proceeds from cause to effect. So we identify the risk factor. We find out that this group is susceptible for that particular risk factor, not for that particular disease. Okay, so the disease has not been developed, but the risk factors are there. So we followed this group over a period of time, and then we find out whether because of these risk factors that disease into that particular population that develops or not. That is the meaning of cohort study. So the design of cohort study is population which has population without disease that can be divided into exposed, that means exposed to the risk factor, or the people who have that risk factor, and people who do not expose to the risk factor. Then we need to find out over a period of time, over a follow-up study, that whoever from exposed group have developed the disease and whoever from non-exposed group have developed the disease. And on the basis of this diagram, ultimately whoever have developed the disease in exposed group and whoever have developed the disease in non-exposed group, the amount of those people will decide whether this risk factor is actually the risk factor for that particular study or for that particular disease or not. Okay, so what are the indications? Where can we do this cohort study is when there is a good evidence of an association between exposure and disease. Okay, there is a good uh, evidence of association between this exposure and disease, which has been already laid down by some case control study or a cross-sectional study. Okay, when exposure is rare, but the incidence of disease is high. So exposure is rare, but the incidence, that means on a smaller amount or a lesser amount of exposure, there is a high amount of disease in that particular community. When attrition can be minimized. So population is more or less constant. People are not moving from here and there, and you can access that population whenever you want to take a follow. Ample funds are available. Since cohort study are quite expensive studies, the issue of fund is always there. So if only there are ample of funds are available, then only we can go for cohort studies. Then what are the rules for selection of a cohort? How can we select a cohort? Cohort must be free from disease under study. So whatever disease you want to study, cohort should not have that disease. The risk factors are there. The risk factors are definitely are there, but the disease is not developed into that particular population. If a person is having disease, then we need to exclude that person from that particular study. Both the groups should be equally susceptible to disease. So made case group or a control group. That means made people exposed or people not exposed to that particular risk factor, they both have equal susceptibility to that particular disease. Then both the groups should be comparable. Comparable means again, how we see into case control study, there is a matching. That means other confounding factors like age, gender, occupation, education, or racial factor or the geographical factor, they should not get into, and they should not be acting as a confounding factor, but those both of these groups should be only comparable in the form of disease only. So all other things should be matched. And then diagnostic and eligibility criteria for the disease should be defined beforehand. So according to you, uh, how we have a operational definition like that, we need to have an operational definition here also, that how much is disease is enough to called as a disease into your experiments. So once the person starts showing that symptom, you can say yes, this person has developed this disease, and now I have to stop my experiment here, and I can put this person into disease category. Okay, so beforehand, before going for that particular study, before even enrolling the participants into your study, you have to have the disease predefined. Okay, so there are examples of cohort into the diagram. That is the cohort of pregnant women. If you want to do your study on pregnant women, or children under 5, children who are under 5 years of age, or men with HIV. So these are the specific cohorts where we say that actually the cohort means they share the common characteristics. So all in this, you can see that the pregnant women are sharing the characteristic of being pregnant, or men with HIV, they are sharing the characteristic of having that particular disease. Okay, when men with HIV, we are not seeking for HIV, but we are looking at HIV as a risk factor for developing other diseases which are dependent on HIV, like that. Okay, then we should go for types of cohort study. So first is prospective cohort study. As I already told you, we start with the scratch. We just have one cohort and we follow up that cohort over a period of time. So we'll understand how many people of that cohort have developed the disease and how many have not developed the disease. Okay, then the retrospective cohort. Now, what do you mean by retrospective cohort here is, uh, actually this is a cohort study, but we do it into the past time. Like how we do it is, we since there is less amount of uh, manpower available, since there is less amount of time available, or there is no feasibility, or the amount that we are spending on this particular case is too much, then we can have a retrospective idea where we can actually have patients who have developed that particular disease, but we go back into the time and we reach where they haven't they haven't developed that particular disease, and we actually take all the data from the hospitals regarding that particular disease. Okay, the hospital records of those patients will be gathered, or questionnaire will be taken from those patients, that what have they done in past so that they have developed that disease in today's day. Okay, so retrospective. So we take people who already have the disease, but we take their data in retrospective manner. We take their data from where they haven't developed any disease to till date where they have developed a disease. Okay, and ambispective means both are both part of studies are there. That means some part of it is prospective and some part of it is retrospective. That means what we do is we have a cohort, we ask them some question from their past also, which is a retrospective part, and again we follow that specific cohort over a period of time to find out how much time it will take to develop that disease entirely. So this will limit the manpower, this will limit the amount that has been spent, that is the financial amount, and that's why the study will be more efficient as compared to only prospective or retrospective study. Then now the steps how we go about this study is selection of the study subjects, the subjects who do not have diseases, obtaining data on exposures. So right now, how much are they exposed to that particular risk factor? Selection of a comparison group, similar comparison group who do not been exposed to that particular risk factor, then follow up over a period of time till they develop the disease and analysis. Okay, so now one by one we will be going for the steps, that is selection of the study subjects. So selection of the study subjects can be from the general population. As I've already told you, the people do not have the disease right now, but they are exposed to that particular risk factor which has been already laid down by cross-sectional study. Okay, so they are already laid down by cross-sectional study that this is the particular risk factor for this particular disease. Now we want to test. So we'll be gathering people from general population who have that particular risk factor into their consideration, but they haven't developed any disease yet. So we take people from general population or some selected group, as I've given you example like pregnant women, or exposure groups like HIV exposed patient or patient who are exposed to the HIV patients, like that. So you can take your sample from them. Then obtain, second step is obtaining data on exposure. So to have that data from them, how they have been exposed to that particular disease, like demographic details, all the age, gender, occupation, then their education, where they live, what are their lifestyles, what are their socioeconomic status, all this data is gathered. And through personal interview, then you need to find out more about that particular risk factor, the habit, how they develop that habit, what is the frequency of that habit, what is the duration of that habit, do they have any discomfort because of that habit. So all this you can go for a personal interview and gather this information. Then review of the past records from the hospitals and retrospective studies, and medical examination or special test. For example, like in precancerous lesion, we can even examine the precancerous lesions with the help of some tests and environmental surveys. So through all this, we can obtain the data on exposure for that particular risk factor. Then on the basis of data obtained, the subjects can be divided into whether or not they have been exposed. Okay, the patient will be divided into whether the patient has not been exposed and what are the degree or the level of the exposure. If they are exposed, then what is the degree, whether they are heavily dependent on that particular habit or they are less dependent. So people, for example, if we take example of smoking, person who smoke 2 cigarettes a day only, then person who smoke 10 cigarettes a day, and person who smoke more than 10 cigarettes a day. Like that, we can divide the data to have comparability between that group. Okay. Then selection of the comparison. So there will be internal comparison, as I've given you example right now, like cigarette smoking. So we can have 3 groups into that one particular group only. So one is the people who just smoke 2 cigarettes a day, one who smoke 2 to 10 cigarettes a day, and third will be one who smoke more than 10 cigarettes a day. So we can have internal comparison group where we can compare between themselves also. So we will come to know how much is the association of that particular habit to that particular disease. So if the habit is increasing, whether that disease is increasing or not. Then the external comparison. So we even can have external groups which share the same characteristics as our cohort, except for the risk factor, who do not are dependent on that particular risk factor. Then we can have a comparability between them. And again, we have to have the exposure data for the external comparison group also, and we have to have a follow-up. And after follow-up only, we will be coming to know how many of people who have exposed to that particular risk factor have developed the disease and how many not. And same for the control group. Comparison with the general population rates, that is less representative controls. So if you do not get any kind of a such controls, you have to have controls from general population, but those will be less representative control. But if you cannot find a proper control, you have to have them into your study. Then the fourth step will be follow. So periodic medical examination of each member of cohort, for example, in pre-malignant lesion for developing of that particular lesion. Reviewing physician and hospital records. Routine surveillance of death records. So if the disease is fatal or deadly, then death will be the ultimate outcome of that particular uh, experiment. So you have to find out how many people died because of that particular disease. Then mailed questionnaire if the patients are not accessible, and telephone calls or periodic home visits to find out the follow what exactly is going on, whether the disease is developing or not, whether the patient is having any discomfort because of that particular habit. Okay. Then the analysis part, that means once you have all the data, now you have gathered the data over a period of time, follow-up time, that this patient, now these are my two groups and these many are exposed, these many are not exposed, and this is the particular amount of people who have developed the disease and who do not develop the disease. So this 2 by 2 contingency table we have already seen in previous study also, that is case control study. The same here also we can see that the people who are having cigarette smoking habit, that is our cases group, who have developed the disease, who did not develop the disease, whereas the second group is patient who do people or participant who do not have cigarette smoking habit, still some of them have developed some lung cancer and some of them did not develop the lung cancer. So incidence rate, since cohort study, we generally get the incidence. Since we are developing a new cases, we are finding out the new cases and we are not relying on the previous cases. So incidence rate can be calculated among smokers and among non-smokers through this formula, that is whoever has developed cancer divided by the total number of patients, whereas whoever have developed cancer in non-smoking group divided by total number of patients assessed. Okay. So relative risk is the best analysis that we can do in any of the cohort studies. So relative risk is a ratio of the incidence of the disease or death among exposed or and the incidence among the non-exposed, that we have previously calculated in this table. So we can just carry forward these values. So you can see that that comes as 10. So what does this 10 means? What does this 10 means? What does this number means? So this means that the people who have exposed to that particular risk factor, they have 10 times more chances of developing that particular disease as compared to people who are not exposed to that risk factor. In this case, I would say that people who are smoking, they have 10 times more chances of developing lung cancer as compared to people who have not smoked cigarettes. So that means the cigarette smoking is contributing towards the development of lung cancer. So if we stop that habit, there are less chances of developing lung cancer in future in that particular patient. Okay, it is direct measure of strength of association between suspected cause and effect. So it gives direct association. That means it says yes, there is till now we were just assuming, but now we can say with the help of cohort study, yes, there is a direct association between suspected cause and effect. Okay. Then second factor that we can find out with the help of cohort study is attributable risk. Now, what do you mean by attributable risk? It indicates to what extent the disease under study can be attributed to exposure. That means how much is the amount of that, how much is the amount of contribution of that particular risk factor in that particular disease. So here is the formula, and according to this formula it comes as 90%. When we calculate, it comes at 90%. So what does this means? That 90%, if if 100 people are developing this disease, 90% of the people are developing this disease due to this habit. 10% may be developing due to some other risk factor, but 90% causative effect is having is by this habit. So if we eliminate this habit completely out of that patient's life, then 90% of the people will be saved of that particular disease. This is the meaning of attributable risk. Then the last one is the population attributable risk. It provides the estimate of the amount by which a disease could be reduced in population if the suspected factor was eliminated or modified. So this is again as attributable risk. So if like if we take previous example, if 90% is the attributable risk, if we remove that risk factor from people's life, 90% people may not develop that particular disease. That is the meaning of attributable risk or population attributable risk. Now, as we already have seen that there are some biases in our previous study, that is case control study. So there are some biases in our cohort studies too. So what are these biases? First is selection bias, then information bias, confounding bias, and post hoc bias. So one by one, uh, so it is exactly similar as we see into our case control study, that is selection bias. If the examiner knows that who are the cases and who are the controls, then they select the cases properly, and they take interview into more detail so that they'll get what they want and they won't treat controls equally. So there will be a selection bias. Second is information bias. Again, if you take history from the patient from very old, like very old history, if you want to extract from the patient, there may be an information bias where patient may not remember that history very clearly, whereas if the information or the event had just happened earlier, like just 2 or 3 days or just 1 year back, then the patient may remember each and everything of that uh, particular thing. So there will be an information bias. Confounding bias, there may be confounding factors, as I've already explained you. The confounding factors are the factors which are both related to the risk factor as well as the disease, and they can actually hamper the relationship between the risk factor and the disease. And the post hoc bias, and there is one more, that is post hoc bias. So what are the advantages of cohort study over a case control study? So incidence can be calculated. Several possible outcomes related to exposure can be studied. So once you follow up, you may even have more outcomes because of that particular risk factor. How many diseases that particular risk factor can cause. Provides direct estimate of relative risk, and dose response ratio can also be calculated. So how much amount of dose of that particular risk factor is needed to develop that amount of disease. As there are some advantages, there may be some limitations also. The very first is problems of bias. Then second is long study or long duration study, which is very difficult to organize and conduct. Technique sensitive. Technique should be very put in pat. Every step should be followed properly. Dropout rates are higher since there are follow-ups and study goes for years. Dropout rates are higher. Reserved for precisely formulating hypothesis. So hypothesis should be so precisely formed that only we can go for a cohort study, and there will be financial barriers since the study goes for long. Now, what are the differences between keynote differences between case control and cohort study? This can be asked as a short note to you. So, case control study generally proceeds from effect to cause, whereas cohort study goes from cause to effect. So, case control study is generally retrospective. That means it goes from now to behind the time, whereas cohort study from now onwards in future. Case control study generally starts with the disease, where the cohort study does not start with the disease, but it starts with the risk factor. In case control studies, tests whether the suspected cause occurs more frequently in those with disease than those without the disease. Whereas in cohort study, test whether the disease occurs more frequently in those exposed than in those not exposed. So here we are studying disease in case control study, whereas here in cohort study we are concentrating more towards the risk factor. In case control study, usually the first approach to the testing of hypothesis, but also useful for exploratory studies, whereas cohort study reserved for testing of precisely formulated hypothesis. For each and every hypothesis, we cannot go for cohort study. Case control study involves fewer study subjects, whereas cohort study need more number of study subjects. Case control study yields results relatively quickly. We just have to go once to the patient. There are no follow-ups, so the results we can get quickly as compared to cohort study. Case control studies are suitable for rare diseases, whereas cohort studies are not suitable for rare diseases since the time span will be too much. The case control study generally yields only estimate of relative risk, that is the odds ratio, whereas cohort study will give you odds ratio, incidence rate, relative risk, attributable risk, population attributable risk. The case control studies cannot yield information about disease other than the understudy, because the patient is already having a disease. We are only concentrating on that particular disease. So we will come to know about that disease only. Whereas in cohort study, will be come to know about many diseases that has been caused by that particular one single risk factor. And case control studies are relatively inexpensive as compared to cohort study, which are expensive studies. Okay, so this is done for cohort study. Thank you.